Good day, all, and welcome to the Teledigm Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello, and welcome to another edition of the Teledigm Pulse. I'm Andy Whitney, Director of Marketing for Teledigm Health, and with me today is Shane Fleming.
Hello, everybody. Shane Fleming, co-founder, CDO of Teledigm Health, and excited to be here for another edition of the Teledigm Health podcast. And Andy, man, we've been so blessed with so many fantastic guests. Given the infancy of our podcast, I'm just shocked that we have more folks that want to come, and the rock stars keep coming. And man, do we have a couple of rock stars today?
We do.
And Chuck Nordyke and Dr. Bryon Schaeffer. And with Clarinda Regional Hospital in Clarinda, Iowa, and I'm excited to really offer up this discussion. This is going to be fantastic. I'm really excited about this, and gosh, our relationship with Clarinda goes back almost 9+ years. I mean, this goes back a long time, even before Chuck, you were the CEO at Clarinda. But really, the vision took off once you came on board, and I remember it was interesting. You're the first hospital that we did the rural health engagement strategy session in, and it was a great session. It took like 5 hours, and the interesting thing with that session was Dr. Schaeffer was there for the entire session. So he clearly lost a bet somewhere. And I don't know. I'm not sure who he lost that bet. It must have been Chuck said, you're going to have to go to this and put up with Shane for that many hours. But I got to tell you, it was a great discussion, great session. And it really comes down to, I've been asked this before on one of the key success metrics, and it's definitely leadership. And we got some good ones here today. And Dr. Bryon Schaeffer and Chuck Nordyke. So I think we'll stop right there and offer up for you, Chuck, and Dr. Schaeffer to do some introductions.
Sure, absolutely. Thanks for having us, Shane and Andy. Dr. Schaeffer and I are thrilled to be here. Clarinda Regional Health Center, just to give you some idea of kind of what we are and where we're at. We're in the lower corner, southwest corner of Iowa. We're a 25-bed critical access hospital down in Page County, Iowa. We're unique in that we're one of the, I think, only 3 counties in the state of Iowa that have more than one critical access hospital in them. So we have direct competition with Shenandoah Medical Center, and really just to the north of us and not that far away is Montgomery County Hospital. So we have some critical access hospitals very close by. We work with them and try to work together. Obviously, there's competition there, but we can do what we can do. Dr. Schaeffer now I've been at the hospital as CEO for about 5.5 years now. I hail from a much larger city over in Chicago. Dr. Schaeffer, though, has been here. This is his second go around, so he's been here like 150 years, I think.
Yeah,
that's it.
Originally for about 3 years, and then for family reasons, I had to leave. But I came back. It's been almost 10 years now again. Just been the CMO here for just about 5 years now, due to the brilliant vision of Chuck Nordyke, CEO. Yeah. This wasn't a position we had before, and so we're still trying to figure it out together a little bit what this looks like in a critical access hospital. But I think we've been pretty successful so far.
Yeah. Over the past 5 years, we've had so much growth. A lot of it has to do with our relationship with Bryon Health and these type of programs that we'll get into. But one of the great things is because we have had so much growth, we've been able to experiment and try different things. And if it works, great, run with it. And if it doesn't, let's make changes and keep moving.
Yeah. Well, I can't emphasize enough that you can't discount the vision and the leadership at all in these situations. You guys have done a great job over in Clarinda and have done some amazing things, you and the team over there. And we're excited to continue to be your partner and have been your partner for several years. And excited to talk about a couple of the programs today and a little bit more about your journey and how you got there today. And by the way, Clarinda is not a typical destination for a guy out of Chicago, is it? I don't know. Is that normal?
There are a couple folks here from Chicago, so.
It just seems like an odd landing spot from a guy out of Chicago, But nonetheless, I know that they're blessed to have you there. Yeah, you had a 5-year run of the Southwest Reader's Best Hospital, named Best Hospital in Southwest Iowa. So a lot of great things going on at Clarinda Regional. And really why we're here today is to do a little bit of a dive into the journey of you, Chuck, and you, Dr. Schaeffer, and Clarinda Regional in their virtual care strategy over the last several years. And it's really morphed. To your point, making some changes and adopting and taking a chance here and there on options and programs and solutions that you think may make a difference. And it's been very successful across multiple fronts. We'll highlight a couple today, primarily acute neurology and stroke and hospitalist, telehospitalist programs and pulmonary, among some other things. But those will be the primary areas we'll dive into today and chat a little bit more about your journey, because it's been an interesting one, really across all those programs, but interested in really hearing some of the detail and your thought process behind a lot of this as you've built these programs. And so let's start off with talking a little bit about stroke and neurology and sort of your thought process and what you're hearing from the medical staff and the nursing staff and patients in the community, what you're seeing in terms of outmigration or transfers related to neurology and stroke situations. So can you give us kind of some insight on the preliminary discussions around stroke and neurology and what was being discussed and what kind of concerns were you hearing or maybe, what types of hesitation and ambivalence were you hearing going into that decision?
Dr. Schaeffer, you want to add your part first?
Yeah. So stroke here traditionally was someone comes in with stroke symptoms and we package them up and send them out as fast as we can. I don't want to say people were panicked, but there was certainly a heightened level of excitement when those patients would come in.
Sure.
Not always real comfortable. We also recently developed a new or built a new physical therapy building. So we have advanced physical therapy, occupational therapy, speech therapy. And so we thought, we could really take care of a lot of these stroke patients too. And so that led us into seeking accreditation for acute stroke readiness. There's a certification through DNV, which is our accrediting body. And part of that requires us to have access readily to a neurologist. We're almost through that process now with this program that we'll get into. We're one measure short yet. We have to have 5 successfully managed TPA patients that we hit the markers on and send out. And I think we're at 4 right now. So we're just about there. So the thing that really drives all of this, of course, is patient care. Better patient care here. If we can keep people here, provide that care, and even if we have to send them out, if they can come back here and receive that post-stroke care, that's valuable too. And so that was really the impetus of how all of this got started.
Sure. That's interesting. We hear that a lot for the mentality of drip and ship and even some of the anxiety that goes along with even doing the drip, even before we get to the ship. Yep. But nonetheless, it's definitely high anxiety. So having that stroke neurologist there is definitely advantageous for multiple reasons. But one of the things we've seen even in the critical access hospitals is a retention of around 73% of all stroke and neuro patients. So even those receiving TPA have stayed successfully in critical access in rural hospitals. Many examples of that over the last several years. And, Dr. Schaeffer, as you think about that, and I know that in some of the facilities, it's been some of the physicians are like, gosh, fundamentally, I've been doing it this way for 20 years. And now all of a sudden you're suggesting we should do this, or perhaps the nurses are a little uncomfortable with it in certain situations. What types of conversations were you having around that?
Well, and we'll get into this a little bit. We've had some less successful tele programs in the past as well. Yeah. But through all those growing pains, the staff here knows what to expect. And, there's going to be some bumps in the road when you get started, but we've done that enough. So I don't think anyone had any concerns when we started this.
Sure.
Something that we'd have to work out. But I got to tell you, it's been an amazingly smooth journey with this group. And I think a lot of it has to do, the technology is great and all, but it really depends on the people you're working with.
Absolutely.
And this neuro group's been phenomenal. For For stroke patients that we've had, I mean, we call them, they're on camera within one, maybe 2 minutes. I mean, they're right on it. I think,
Mhm.
and the other advantage is even besides stroke, we can use them for other neurological problems in the ER. And so I think the longest wait anyone's ever said they've had is like 15 minutes. So they're very responsive, and it's just been a great program. Patients are super appreciative. I mean, they can't believe they're sitting there on the screen talking to a neurologist almost immediately in our ER. So for the community too, it's been a really big win.
Yeah. It's interesting in that you mentioned the family, and oftentimes when patients are coming into the emergency department, sort of the front door of a facility, or maybe they're not coming into the front door, they're just going straight to a tertiary center, for example. But offering that up in that grassroots effort locally to have those patients and let them know, hey, we could take care of you here. But beyond that, if the family is engaged in saying, golly, I don't know why, Mom, we can't stay here. You got to be transferred. They don't have a neurologist, but yet here's a neurologist on the screen that can then talk to the family and give them a lot of reassurance of, hey, here's what we're going to do there. Very capable staff there. I'm going to be right here available at your beck and call for the next 24 hours if something goes haywire. And oh, by the way, we're going to be doing the exact same thing there that we would be doing here. So you're better off keeping the patient there. Do you think that's helpful from time to time?
Oh, absolutely. And another nice extension of that program is then if we do keep those patients here, they can actually round on them in the hospital too. So we have that follow-up care with the neurologist who can work with our hospitalist and also with the therapy department and so on. So really direct that post-stroke care as well.
Sure, and I have to assume I'm interested in your perspective on this. If they do. The confidence that having that neurologist in their back pocket gives them in attending to those patients on the inpatient side of the equation. Would you agree with that?
Oh, absolutely. We're definitely keeping patients we wouldn't have kept before.
Yeah,
not because we're
awesome.
capable. We just didn't maybe know that we were.
Well,
and having that reassurance is really key to that.
That's half the battle. Is really just saying, listen, you're doing great. You're doing the same thing that this physician would be doing in the tertiary center, and you guys are knocking it out of the park. But it's so helpful just to have them at your beck and call and ready to respond when they need. So I can't agree more that having the rock star team available, similar to your leadership team, is really what wins the day there. Chuck, any thoughts from your perspective on this?
Yeah, so I've told you when we first started talking about this, I'm not a huge fan. I'm sorry, I was not a huge fan of telemedicine. I think you need to have that relationship. I do see a spot where telemedicine is needed, and in order to expand services, but I had not been a fan of it, just primarily because the programs that I had worked with have not always been the most warm and fuzzy, successful programs. So getting into this and seeing how much success instantly, I mean, like overnight, you heard providers talk about how great the partners were. You heard the nursing staff and getting that confidence. We saw messages in the community about, oh, Dr. So-and-so came and saw me and did this. And that was great. I think I told you this story. I ran into a daughter whose father was, he was kind of grumpy and started having some neuro symptoms, but didn't want to come to the hospital. So she got him in and was able to see a neurologist right away and get everything taken care of timely. But one of the bigger things that came from that discussion and kind of what we want to get out to the public is, oftentimes when these neuro things start happening, there is a window of time. And if you are not under the proper level of care quickly, you may fall out of that window and then nobody can help you. So we want to make sure that they understand you get here timely. You give us plenty of time because we're going to have a neurologist right there to get everything rolling. And if we do have to transfer you, we will. If not, we'll get those same things going here very, very quickly. So that's been just huge. And like Dr. Schaeffer says, the fact that you see the same neurologist or same group at least over on the floor, and they can round on you while you're here, and that's just tremendous. It's tremendous. So now I'm a believer.
Chuck,
Well,
my recollection of you not being a fan of telemedicine, I don't remember it exactly like that, but maybe a little cantankerous out of the gate, I suppose, similar to that patient who was a little grumpy having to come to the hospital, I suppose. I can't imagine you have some elderly males around there that could be grumpy having to go to the hospital, but
Yeah.
That's part of the coming from Chicago to Clarinda. I've kind of developed the onion mentality, like a lot of the farmers have here. You got to kind of just peel us away a little bit.
yeah. Yeah, well, there's been a lot of peeling. That's for sure.
Yep.
Over the years, and I can't agree with you more, Chuck. I know you have a nursing background as well. The time is muscle. Can't emphasize that enough. And your point is an extremely valid one. Wow, you need to get to the hospital ASAP as soon as you are experiencing any sort of symptoms. And that's why Clarinda Regional is so well positioned to handle these types of emergencies. And in the event you do need to be transferred, that's going to be facilitated. But I got to tell you that a lot of that stabilizing treatment, the sooner you can get that on board. I mean, each 60 seconds that goes by, you're killing off brain cells and tissue, and the outcomes are dramatically. It's statistically proven. It's based on several research articles and meta-analysis, et cetera, on success and brain survivability based on time. And so not only do you have that expert care available right there in Clarinda Regional, and then to assist and analyze what the next best step is, but man, it could be the difference between potentially not making it at all or having a near 100% recovery. So it's a big deal. It's a big deal.
It is.
In our therapy team here, which is, I'll put them up against anyone. They're the best therapy team I've ever worked with. With their new facility, they get to start seeing the patients in-house when they're in the hospital, and then transition them as outpatients to continue to work with them and continue their plan. Also, with the greatest thing about the telemedicine program, to me is, and I've said this numerous times, you have folks down here that don't have transportation to get up and see loved ones and family members when they're in the city, and people don't do as well. If you don't have your support group there to help you, you're not going to recover as quickly or as well as you will if you have them. So having them local, we tend to get all the visitors and the family, and that support system is established here. So that's been a great add for this level of patients.
Yeah, absolutely. We've had quite a few, I shouldn't say quite a few, but several of the critical access hospitals that have deployed neurorehabilitation strategies as part of their, and it's really worked well. So kudos to that. For that, Chuck. And again, keeping as many patients in your sandbox in various methods is absolutely the way to go. And I just said sandbox, and Dr. Schaeffer started to twitch a little bit because he remembers that 5-hour strategy session he sat through.
There was a lot of
I see he's trying. We might have to get a neuroconsult on him, actually. Right?
There was a lot of sandbox talk in that conversation.
He could be patient number 5.
Well, there you go.
We do not need that. That's for sure. Well, so we're several months into the program. And you've mentioned you've definitely kept patients there that have otherwise been transferred, and you mentioned some satisfaction through the community. Any other points of impact that you think the program has had? And you mentioned accreditation, and we've helped some hospitals with accreditation on stroke certifications of various types. Anything specific you're hearing from the med staff or nursing staff, or additional outside comments from the community?
From the medical staff, they really appreciate the input from the specialists, and I know we're talking about neurology right now, but other ones as well. Again, it just gives them that extra level of confidence to be able to manage that patient. And also, sometimes when let's say they're rounding, when the hospitalist is working with the neurologist and making those rounds, they manage up, they support each other, and the patients see that, and it really helps the overall experience for them. And I think probably the best thing for the providers here is a big part of medicine is experience. You know how to do something because you've seen somebody do it, you've maybe done it yourself before, and that's how you progress. And so by being able to keep some of these more complicated patients, that level of comfort managing those increases, the whole medical staff gets better, and actually the whole staff at the hospital, right, nurses, everyone feels more comfortable managing more complicated patients, and it's just it makes the whole place better.
Sure. Do you think that's interesting? I'm going to press on that just a little bit. Do you think that it's in terms of medical staff satisfaction? Do you get the sense that providers feel like they're more empowered to offer more care locally and maybe feel like maybe they've achieved more in their practice by having these types of resources?
Oh, absolutely they do. Yeah. And oh, go on.
Honestly, talking to some of our hospitalists that are boots on the ground, they have reported back and said it gives them a lot more confidence in caring for this level of patients, and they love to learn. So working with the group, they get to ask questions and develop that. But also the nursing staff, they've been able to do the same thing and feel more confident in these patients. So.
Sure. Now, Tyler, the CNO there, has done a great job with these programs. As I've said many times before, the nurses are the linchpins in a lot of these virtual programs. Despite Chuck not being a big fan of these several years ago, but we're making progress to shift the tide there. Well, you mentioned hospitalists. That's a great segue into our next discussion, and this is a very intriguing journey, Chuck, on your process to launch a virtual telehospitalist program. I know, golly, the conversations on this go way back, but you had. You've come to the conclusion you needed a hospitalist program for various reasons, and that sort of progressed into various boots on the ground strategies and recruitment strategies, and then that led to a virtual hospitalist program that didn't work out so well. I'll let you chat about that here in a minute. And then that led back to a program where you brought more boots on the ground folks in, and then some more turnover there, and then that led us to where we decided to deploy our telehospitalist program as part of your strategy as well. And so I think it's I'm interested in you just kind of describing your journey and your thoughts and your challenges throughout that journey. And because I think there's a lot of people in your shoes and facing similar challenges that you and your organization did as you went on this journey.
Yeah, it's one of the reasons I wasn't a fan of telemedicine. But we had, when I first got here, the medical staff were doing everything. So they would see clinic patients, go out on the floor, do surgery. They were just doing everything. And it's not a good model. It's not a good work-life balance. From a business strategy standpoint, it's horrible. You see all your patients get shipped away very quickly, so the community aren't happy. So many things wrong with it. So we decided very quickly we were going to change that and create a hospitalist model so that our providers that are in the clinic can focus on the clinic patients where you have a huge volume, and then we can see if we need to what we need to deploy down on the floor to grow and go from there. So one of our very, very good internal medicine providers in the clinic volunteered to go work as hospitalist, and
encouraged to volunteer.
Yeah.
She ended up loving it and did a great job. And then for family reasons, she was relocating. So we were kind of at that point of like, what do we do? But while she was there during the day, we still needed additional coverage at night. So we looked at a telehealth program to kind of do that night coverage. And prior to implementing it, our ER providers were kind of covering everything. And that was working okay. But again, when they're busy and so forth and trying to get everything covered the best we can, going to a teleprogram would have been maybe a better option. And we received a grant. So most of it was covered for the first year. So we did this change, and it was from the very first day I was regretting it because, we had to kind of talk the staff into making this change because it was something different. And when they weren't getting the phone calls returned quickly and the responses weren't what they were used to, and all the negative things you can think about, just made me look bad as the one that rolled the program out. And again, I think it goes to what Dr. Schaeffer says. Those docs, in their defense, they didn't want to do this program. They were kind of told to do it, and it showed in their work. So we stayed with them for a little while to see if we could work through it, and it just wasn't something we could do. So we left that program and went back to essentially one provider covering 7 days a week on call, and that's not a good model for long term. So when our day shift internal medicine doc was moving, we just so happened to have a husband and wife team kind of fall in our lap, and we brought them on board and had some APPs that were working with them to fill coverage, and it just wasn't a good fit. They just weren't a great fit for a small community and wanted to go back to a larger city. So we kind of went through that for a while, transitioned out of that, and that's when we started talking.
Yeah.
And here we are today, and much happier. And overall, it's way better than any model that we had planned prior to this.
And I don't think problem with the previous program. I mean, it's not telemedicine as such. It was the way that program was set up, and I don't really know what those docs. I don't know if they were seeing patients during the day and trying to do this nighttime coverage. I don't know how many other hospitals they were trying to cover, but we would, hear things like, I'm real busy. I don't have time for this. I can't help you with that, which is obviously not what you want from your
Sure.
telehospitalist.
Yeah, right.
That was a big part of why that wasn't successful, and then probably where Chuck got his original negative opinion from. And also, I'll be honest, when we went into other programs later, like I said, we've had those growing pains, that put a bad taste in a lot of people's mouth. And so we had to really convince
Absolutely
nursing staff and everyone to we're going to try this again and we're going to do it better. But, it took some convincing.
I think the nursing staff winning them over was the biggest thing, because they could make or break a program very, very easily.
Oh, no
Yes,
doubt about it. No doubt about it. And you kind of hit the nail on the head. Chuck, you recall the convincing you had to do to roll out this significant fundamental change in the way care is delivered, and then it fails, and there's all kinds of problems. Which incidentally, the definition of a hospitalist or a telehospitalist program is not always the same in terms of when you're talking to folks about a hospitalist program. Their vision and definition it's a lot different than others. And so getting clarity around exactly what you want to accomplish on that it can be a challenge sometimes. But you're absolutely right. This isn't the first time we've been involved in replacing a failed program, and there's across all kinds of different disciplines. But the story's the same essentially, in that you get into these rooms, it's either the medical staff or the nursing staff or both, and they sort of have, Chuck, you're standing in front of them and you're saying, well, we have these challenges here, and I think the next best step is to launch another virtual hospitalist program. And what's the initial reaction? I mean, now, did you clean the room first, make sure there's nothing they could throw at you before you roll that potential message out? And then, or did you say, now I have to leave, Dr. Schaeffer will take it from here, I'll be back in about a half hour? Is that how you kind of went about that?
Well, part of his job description is that I have the right to walk into a room and say, Dr. Schaeffer has something to tell you.
Yeah, that's right.
And I leave. But no, I think, it was one of those things where we had long talks about what's the best way to roll this out and kind of save face. And, and really going back to the provider that was doing the 7-day coverage and saying, look, let's do some other stuff with you, have you work on some other projects. And I need you to sell this. I need you to believe in it and get it out there to the staffs, which they did a great job, and the staff kind of trusted us. Plus, honestly, I mean, we had moved a lot of staff from the night shift that were having problems. They went to day shift, over time. So that kind of helped also.
Sure.
But the folks that stayed on nights, they were willing to give it a shot. And, we just had those conversations and told them, if you experience anything, let us know. And one of the greatest thing was, Shane, having your cell phone and Dr. Bossard's cell phone. I told him, I said, if you guys call me at 2 a.m. and tell me there's a problem, I will directly communicate with them and we'll get it taken care of. And I think they know I've kind of, if there's a problem, I'm going to jump on it right away. So I think they trusted that and felt like, okay, we don't really have a choice, so let's give it a try.
Yeah.
But it's been good. It's been
Yeah.
positive.
Well, and one thing I like with your group, I mean, nothing major's happened. We've had a few little bumps along the way starting this out, and we've been right on it. We've had meetings. We're all adults. We talk through it, and these are just problems. You solve them, and it's been really a good collaboration, getting that all worked out, and now we're in a really good place.
Yeah, I recall, the other couple of programs we had moved out, and then when we had the hospitalist discussion, sitting around the table, and Chuck in your eyes, and Dr. Schaeffer in your eyes, and Tyler's eyes, and you could just see, is this really is it really gonna happen this way? I mean, can we really trust these guys to really pull this off with us? And so I can't emphasize enough that we take that very seriously. And the last thing, holy moly, that we would want to do is put your leadership team in a position to have to say, look, this is a disaster. Holy cow. I apologize. And so we definitely understand that. And two things. One, again, exceedingly appreciative of trusting us to the point of working with you collaboratively to roll this out and partner on that program, among all the others. But that's, I know for sure that one had there was a lot riding on that one for sure.
There was a lot riding on that one.
And I think he was still a little tepid on. I don't know if he would say he hated telemedicine back then, but I mean it was definitely he wasn't warm and fuzzy about it. I know that
bad
for sure.
Experience, and it's going to stick with you.
Yeah. Well, unfortunately, we run into that a lot. It's not necessarily, a lot of folks just recall what they know and what their experience has been with a specific program or virtual strategy. And there's been a lot of bad ones, unfortunately, over the years. And it's hard. It's hard to convince a team and an organization to say, maybe this is different. This time will be different.
Well, and they're not all apples to apples.
No, they're certainly not. Certainly not. But again, I can't emphasize enough. We're just simply one of the pieces of the huge puzzle for these programs. It is the local leadership, the local medical staff, the local nursing staff, and everybody working together. To Dr. Schaeffer's point, you just got to solve problems here and there and challenges. If you address them quickly and get them resolved, and you're there to support, and just to have an organization that you're working with that is just as uncomfortable as you are if something's not going perfect, then that's who you need to be working with. So
exactly.
And I think that's key is we emphasize, and this might be hard for you to believe, Shane, but when we sign an agreement with somebody, we're partners, and you have to be invested in that as much as I am. And I am not a friendly person when we're in a contract where that's not happening. Because I believe in what we're doing, and I believe in being that partner. And like Dr. Schaeffer said, there will be some hiccups with every agreement, every partnership, and you can just work through them. But when that doesn't happen, and someone's here to save us, that's not a good fit, and it doesn't end well.
Yeah.
So this has been really great, and then stacking other services on top of the success that we've had as we continue to do. It's because we've gained that trust, and we see the positive, and we'll continue to work in that partnership.
Yeah, absolutely. Can't agree more. So how about in terms of as the hospitalist program, I know it's still fairly early in the hospitalist phases here over the last year. What are you seeing in terms of, Dr. Schaeffer, you referenced the nursing staff hasn't come looking to lynch you anytime soon and cause major problems. But what are you hearing from the staff? Or Chuck, you referenced a couple of the patients in the community. You've talked about the stroke and neuro program. What are you hearing from the patients, the nursing staff, the medical staff, and then because at the end of the day, I put a lot of value in that, because in a small community, they're talking with people, right? I mean, they're at the grocery store, they're at the restaurant, they're at the bowling alley, wherever they're at, and the hardware store, and they inevitably end up talking about the hospital in the small communities. And what are you hearing? What are they hearing out there?
It's been very positive. I mean, nursing staff, it's worked out great. Like I said, they've been very responsive, timely, response to requests for things and all, and that makes all the difference for them. They just want to take care of these patients, and they need help and permission to do so. So that's been great. With the patients themselves, now we do have availability during the day, but they're primarily providing that nighttime coverage. There's not a lot of interaction actually between the telehospitalists and the patients at night like that. But the patients do know that they're consulting a doctor, asking those questions. The other thing that's nice with our program, and I think we've learned this from doing some other ones, is that we have those APPs here during the day. So we have boots on the ground, people and faces that they can relate to, and I think that makes a big difference for the success of some of these programs. So there is that personal touch, that person they can relate to. But it's real important, obviously, that they work well with the top telehospitalists then, and that everyone's on the same page with things.
Yeah, absolutely. We've definitely seen the most, I would suggest, based on our experience over the last 10 years, the most palatable model and the most successful model is definitely daytime APP coverage or local provider coverage, or a combination of both, and nocturnal hospitalist coverage, where we're handling all the admissions and rounding and cross cover call, those sorts of things. So it's definitely a powerful model, and in many instances very sustainable. The nice thing with this program, Chuck, compared to where you were before, of maybe worried about physician X and Z moving or leaving or something coming up, now you're back to ground zero having to recruit. In this instance, there's a lot of bandwidth and bench strength on your virtual hospitalist program that can also flex to assist during the days if needed. So it's a little bit of reassurance on that front. Does that cross your mind ever as you think about these programs?
Well, the last week with all the snow, I thought we may end up having to do something with that, but fortunately we had some providers local that were able to come in and cover. But absolutely, it really does. When it's one thing that I don't have to worry about for the future, it allows me to focus on other things. But I'll tell you, one of the biggest compliments that we have gotten out in the public, and I'm fortunate because I get to be the one that gets a lot of the credit, but I really don't do anything. But I'll take the credit. When I'm out there and I hear how thankful that the community is because of all the expansion and different service lines that we've done and things that they can do, so that we do that, so that patients can stay here, that's tremendous. I always love hearing those stories, but also on a bigger level, when you're talking, economic development and whatnot as a city, one of the big things, one of the key things to make a city successful is healthcare. And when I first came, we were always the hospital, and we were talked about in a favorable light, but we weren't one of the big players. And now with the successes that we've had, we're the largest employer in town, and we're someone at the table now that can help to drive success for the city. And I always say, the city's success is our success, and our success is the city's success. So with a good school program, a good industry, and healthcare, you can go a long way. And we actually feel like a much larger entity than the critical access hospital that we are.
Yeah, I can't agree more. We emphasize that a lot. In fact, going even back to the rural engagement series that we did, the engagement of the community is so important, and the industries locally are so important, and it's a team effort across the board. And it gives you a great opportunity to sort of shine a light on all the great things you're accomplishing at the hospital. And oftentimes the hospital is just sort of this foregone conclusion, they're going to be there for us. Well, maybe not. In today's day and age, maybe not. But you're a great example of how rural hospitals can absolutely be a shining star, even shining brighter than many of the regional hospitals or tertiary centers, by the amazing things that you're doing for you and the patients in your community. So, again, can't emphasize enough the value that brings to a community. Let's switch gears a little bit to the outpatient side of the equation, and kind of as we talked in the acute care side and sort of facilitating that growth of a neurorehabilitation strategy, let's shift gears to the outpatient side of the equation and talk a little bit about pulmonary and respiratory strategies, respiratory rehabilitation strategies, and the growth that you've seen by moving this program out in Clarinda.
Yeah, we had pulmonary coverage at one point here. And we knew that was something that we would be able to successfully continue. having this program has been really well. It's been a positive service for us in that, again, those folks don't have to travel. And a lot of them are elderly and have comorbidities that make it a little bit uncomfortable or difficult to get far. So that has been really a good situation. And then also, again, having that expertise that our providers can bounce ideas off of, or even, the APPs down on the floor for inpatient coverage. We've used them for just to bounce ideas off of and talk through. So it has truly expanded the services. We've done a lot here with equipment, and we've been really fortunate and blessed to be able to get grants and different things. So we have a state-of-the-art, brand new body box for PFTs. We can do children and whatnot. So having a pulmonologist that is ordering those and reading the results for us, that's been great. And then with our sleep study program, kind of going down that path for a lot of folks, that has been tremendous too.
And another thing that's been great, having that resource and that support is tremendous, but also to having a well-organized program. So with the pulmonologists that we work with through you guys, very regimented as far as if they're seeing them for this problem, I'd like to, I want to have this chest X-ray before, and I want that new set of PFTs, or and then so that when they have that appointment, it's actually meaningful. It's not just like, oh, well, we need to go order these tests now. And so putting that together on the front end has helped a lot.
Yeah, that's great. That's great. These programs, the downstream ancillary implications are really powerful options for rural hospitals as they think about their strategies moving forward. And certainly, sometimes it's a little bit more difficult to quantify the community ROI and how that really feeds back into the hospital. But there is definitely something to be said for that. I think it helps generate momentum in the community. It helps perpetuate further activities locally. It's no different than if that's one of the individuals sitting at the table in your economic development planning committee, and I can get my PFT done right here now, and I can see the doc right here. I don't have to go to Omaha or Kansas City or wherever they're going for their services. And so those are big things, and I think it helps perpetuate those ongoing conversations of when the hospital says, "Look, we need to do this, and we need this to happen in order to do that. Can you help us do that?" And so I think it's a great segue into having those types of conversations. So that's outstanding. So Dr. Schaeffer, how about from a CMO's perspective, what do you think about when you sort of take your provider hat off, put your CMO hat back on, and think about from a more of a broad view across virtual strategies and what you've seen over the last 10 years in your organization and I guess in a couple of years in another organization. And from your perspective, what do you see with the progression of these types of services and what you've seen going on in the care settings at Clarinda?
Well, I mean, it's a lot of what we've already talked about, but from the medical staff standpoint, just having that support, being able to manage those more complicated patients, and like I said, the I don't want to say accidental, the education that comes along with that, whether you're looking for it or not, to manage those patients, like I said, just makes the entire medical staff better, more competent, and that spreads out into the community. And as we've had this growth, more growth promotes more growth. All these programs have just built off of each other, and as people become more comfortable with that technology too, they're very accepting of this. I don't think we have any problems with anybody willing to see a teleprovider at this point. And we actually have many specialists that see patients that way here now. So the more we can do to grow healthcare in this area, because we're a fair distance from a major tertiary center, and so the more we can do here, the better off the whole community is.
Absolutely. Well, that's great. As we kind of nudge into the closing arena here, Chuck, I'm interested in, just to kind of combine we've talked a little bit about community perception and what you're hearing out in the community, and you've mentioned some things related to economic development. But based on your experience, and I know I think you've, at least I'm sensing maybe a little transition from where we were a few years ago about hating telemedicine to now at least being in the right scenario and situation and right partner, a solid option and solution for many. What do you think, if you're speaking to your rural hospital CEO colleagues, and they've, because again, many of them are dealing with the same issues and scenarios that you've had to deal with. What do you suggest to them when it comes to virtual strategies, and what would you recommend they do about that as they explore or perhaps embark on their journey?
Yeah, and I've had these conversations. So I always say, obviously I'm going to recommend the Teledigm solution, as I call you guys. But looking at it from a business standpoint, purely, just that level, you're able to provide a level of care at a much lower entry point than if you were to bring in a provider and have them on staff. And then there's the question whether or not that provider is going to stay, because the volumes aren't necessarily what they would be if they worked at a larger facility. And cost-wise, for the hospital, is that something that's palatable for a long period of time? The other piece is being able to recruit the necessary positions, such as family medicine or internal medicine. One of the things we get asked when we interview is, do you have this service? What kind of specialist do you have? What do you have for this? And I was a little bit nervous at first talking about the teleprograms, just because I didn't know how they would be perceived. But I'll tell you, I don't think any of the providers we've talked to even balk at that. They're like, that's great, that's wonderful. They love to have the resources they can get and go after. So also, you hate to bring this part up, but it's a truth. If I'm working with a provider that I've hired now and spent a bunch of money to recruit and bring here, and they were great in the interview and onboarding, and then they get here and they're not so great. Now I've got to spend time and money and hurt feelings and, to transition that person out and try and recruit. Mm-hmm. With these types of programs, we could, one, try to work through the situation, like you would. But also then if that didn't work, we can ask for a different provider to be brought in. And, that could be a solution that works, and it works for both sides, because maybe it's just not a good fit on both sides. Much more tolerable than all the hurt feelings and whatnot that go into replacing a provider that you just brought on. So I think there's a lot of things there that you have to look at for the positive side. Also, some of, like, we're DNV accredited, going through some of the standards. We're exceeding those. What are the types of services that we provide? And that's thanks to you guys. And we're able to bring that up with the surveyors when they come on board, and they're like, oh, great, that's wonderful. So definitely positives for us. It gives us a lot more confidence in what we're doing. And again, just allows for us to continue to think about the future. And I know, Shane, I sent you some text yesterday. It's just one of those things where at 2:00 in the morning, I might have a thought and say, I got to ask Shane that in the morning.
Yeah. Sometimes it doesn't wait till the morning.
Yeah, that's true. That is true.
That's it. That's just great, though. That's exactly the way I want it. And that's what partners do at the end of the day, mm-hmm. is, bounce ideas and questions off each other, and you being successful is in our best interest and vice versa. So it's really a team effort here for certain. So in terms of, you mentioned future. I'm interested in your thoughts on the future. You and I've talked briefly about a couple of other options that are moving down the pipe in terms of as we reimagine healthcare moving forward and continue to, you know me, you've known me long enough to know it's always evolving, right? It's evolving continuously. But I'm interested in your thoughts on in the future, what do you see as roles and models and additional fundamental changes in the way we deliver care moving forward?
I think Dr. Schaeffer will agree with this one. I keep waiting for you to come up with the virtual CEO model so I can sit at home. And,
well, we have one of those, but I got to keep that on the down low. The CEOs get a little nervous when I start talking about that one.
we did do previously at the company I worked for. I had multiple hospitals I covered, and we had to do meetings like that. There would be days I'd wake up and I would be the CEO in 3 of the buildings. So that is definitely something. But thinking about, the the issues with recruitment, and the obvious one is the nursing shortage. So
Yep.
looking at that, and you and I've talked about that, and I know Tyler's going to reach out to you and discuss it further. Interested, and I just think it was a concept at first that I thought I don't quite get that one, but after hearing some of it, I think it's very doable and an ideal model that we should roll out. But I then started saying, okay, what about expanding that into other services? That we were looking at, like we grow our own lab folks. We can't necessarily get lab techs, so let's bring them on and train them here. What about a virtual training program, or radiology with limited radiology capabilities, and what can we grow there for some of their services? So I definitely think it's possible. Honestly, I can see, as we talk about pre-registration and kiosks as folks come in, self-registering. What about having a virtual assistant that pops up and visually it talks to them and sees them and helps that component? So I definitely think with what you guys are doing and with all the other increases in technology that are out there, I don't remember the exact model about the having the rooms all wired. So, you guys could just pop right into a room and start talking to a patient after you knock on the door. Those types of things are amazing, and it will expand our services and help deliver a higher level of care than what we're capable of doing, just because it's an extra set of hands, basically. So I'm excited about it.
Yeah.
And clearly, like you said, there's going to be there already is a nursing shortage. It's also a physician shortage too. And so, coming up with creative ways like this, where these specialists can expand their scope, seeing patients in multiple different places, that is going to be the future. I mean, there's just really no two ways about it. And the APPs are great, and they have they help us a lot, but they still need physician oversight on some of those things. And there's really no other way to do it. We're not making more doctors. I mean, we have the pretty set number of medical schools and number of physicians coming out every year. And so as the population grows and that need continues to grow, solutions like this that is going to be our future.
Right. And I think and I agree with that 100%. And I appreciate your insights there. Certainly what we've seen over the last 10 years is to that point of, I think just the general human desires to want to learn and to improve. And sometimes when you don't have access to all these resources, you just kind of become stagnant in what you're doing. And you just kind of fall into these trends of, I don't have ID here, so let's just transfer them. Or I don't have Palm here, let's just transfer them. We don't have a stroke and neuro, let's just transfer them. Well, not only that do we get to keep them here, but then the providers are learning so much from these experts that they're able to talk to. We have to have collaborative physicians on the screen regardless of the specialty or this doesn't work. But helpful, responsive, collaborative physicians who are nice to work with are paramount in these discussions. But the learning curve, it just elevates the game locally so much to have that expertise available. And we've seen that over the last 10 years. And one of the things I think that, Chuck, you mentioned the nursing shortage, which I completely agree. It's off the charts in terms of the nursing shortage. But the other component, I think, is what a lot of the focus has been on is pumping out new nurses, not so much medical students at this point, right, Dr. Schaeffer, but nursing students. And the challenge with that is we're seeing nursing students with very limited clinical experience, in some cases, if any, that are now tasked with taking care of these patients. So we have to find ways, from my perspective anyway, to support those nursing staff constituents and help them and help them grow, just like a lot of the medical providers have grown in their confidence over the years in taking care of patients. Again, as a nurse, one of the things I dealt with many times is nursing staffs that were concerned about taking care of a certain patient they've never dealt with before, haven't seen before, too complex for them for whatever reason. So having that expertise available is a big deal. And then beyond nursing, we're seeing the augmentation of, say, respiratory therapy, whether it's a knowledge deficit issue or just supplementing respiratory therapy strategies at the local level is a big need, therapies in general. But it goes even beyond that, where we're talking about, pharmacy at the point of discharge for high-risk meds at discharge, and pharmacy and the integration of language assistance and interpretation, case management, social work, pastoral care, and the list goes on and on and on. But really, consuming what you can locally across those specialties, leverage that virtually, or supplement that as needed externally is kind of the way of the future from our perspective. And I know I'm excited to go down that road with your team, Chuck. I know it's a great venue to do that, and can't think of a better team to really help pull that together and move that forward. So looking forward to that here in the future. And anything else from your perspective, Dr. Schaeffer or Chuck?
No, it's been a great program, and we're excited to continue it and expand it as we go.
Yeah, I agree. I think working with Teledigm has been a godsend compared to what we've gone through, and I love the idea of just being able to bounce ideas off of you, and whether you have a solution now, I know I at least seeded the information and you're going to work on it, and then you come back with something. So you haven't told me no on anything yet.
Yeah, I want to emphasize a lot of times I won't say no. I said we could build that, and my team is our team here is just it's incredible, and they've put up with a lot of guff for me for 10 years now. But it's really an amazing team, a dynamic team that really helps bring this type of service to you and supports it in the way that what we articulate is going to happen. We know one of the comments I think in a previous podcast is, you said this was going to happen. That's exactly what happened, which is very helpful for us as we try to move these programs forward. At least that's our attempt to do that, or if we have some bumps to get them fixed. But in the end, we're just appreciative of rural health care, and anything we can do to help support rural health care and keep rural health care strong and keep rural communities strong is what we're all about. And I can't thank you, Dr. Schaeffer, and you, Chuck, for taking time out of your busy days, to sit on a podcast with us. For golly, we're hitting an hour here almost by the time we got our early conversations out of the way. So I can't emphasize enough. Really, really appreciate your time, and honored you agree to come on our podcast, and just beyond grateful. So thank you very much for all your incredible insight.
Okay. Thank you.
Yeah. Thanks,
again,
guys.
thanks for having us.
Yeah. We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@TELEDIGM health.com. For more information or general inquiries, please visit teledymhealth.com.